Patient with locally advanced head and neck cancer, particularly patients unresected, are treated with chemoradiation with high-dose cisplatin. And the prognosis of the patient, despite this heavy treatment, remain quite poor because we have only 50% of the patient alive at 5 years. So we know that in head and neck cancer, in the recurrent setting, pembrolizumab and nivolumab improve survival. So it was logical to try to improve this patient in the curative setting, in the locally advanced disease, to try to add to chemoradiation pembrolizumab. We took patients with locally advanced squamous cell carcinoma of the head and neck, as I mentioned, unresected. And these patients were randomized between chemoradiation plus pembrolizumab versus chemoradiation plus placebo. We include 804 patients. Pembrolizumab was started 1 week before chemoradiation, was given every 3 weeks, and we gave 17 cycles, so around 1 year of treatment. The primary endpoint was event-free survival, so this is an endpoint that includes death, progression per RECIST, and also pathological proof local regional relapse, because RECIST are not able to capture all the progression or treatment failure in this disease. Indeed, the primary endpoint was event-free survival in the intention to treat population, and we did not meet the primary endpoint with a p-value of 0.04 and hazard ratio of 0.83. But we had a trend in favor of chemotherapy plus pembrolizumab. If we look at the 2-year event-free survival rate, it was 56% in the control and 63% in pembrolizumab. The median event-free survival in the control was 45 months, and it was not reached in the pembrolizumab arm. But statistically, it's a negative study because the p-value was 0.04 and the efficacy boundary was 0.02 for this trial. If we look at the survival on the intention to treat population, it was similar between the two groups. In the subgroup of patients, the 2-year event-free survival was 62% in the control and 71% in the pembro arm. When we look at the overall survival of this patient, the hazard ratio was also in favor of overall survival, with a 3-year overall survival rate of 73% in the control and 79% in pembrolizumab. But this is exploratory analysis. When we look at the safety, we did not detect any new signal. We had the toxicity of chemoradiation and also the autoimmune toxicity in some of the patients, but nothing new. So in conclusion, we observe a trend in favor of pembrolizumab plus chemoradiation. According to the statistic of the study, is not significant. Our data suggests that if we select the patient for a PD-L1 expression according to the CPS score and with the methodology used in the trial, we may enrich the population and have a better outcome. But this needs to be investigated in further trial. I don't think that we should change our standard of care based on this study, but it gave a positive message, and I think we should continue to do this investigation of immunotherapy in locally advanced head and neck cancer. That's a very good question. Indeed, that's not an easy disease for several reasons. First, it's a difficult area. We have the speech, the breath function that you need to keep. So you have not only to cure the patient, but the patient should have also a good speech function, able to swallow after the treatment, able to breathe. So this is make things a little complex. We have basically 2 kinds of treatment. We have surgery, followed by radiation or chemoradiation based on prognosis, or we have primary chemoradiation. And we choose a treatment indeed based off the functional result that we can have on the patient able to breathe, to swallow, and to eat. And so it's indeed difficult because you need a lot of expertise to treat this patient, and this expertise of different areas. You need good surgeon, you need good medical oncologist, you need good radiation therapy. You need also very good support in terms of psychology, but also in terms of speech function, in terms of physiotherapy. So it's a really multidisciplinary disease. Also, it's for the majority, it's a poor population, meaning that drinker, they are smoker, and so the compliance also you need to work with the patient to improve that. So for head and neck cancer, the only subside that is concerned with HPV is oropharynx cancer. So now we start to vaccinate the boy and the girls. So we should expect maybe a decrease in the incidence of this disease, but not before 20 or 30 years. So today, the prevalence of HPV positive oropharyngeal cancer is still increasing.